Thanks, everybody, for coming to this session, our annual session on the Medicare Trustees Report, or as I like to think of it, everything you wanted to know about the Medicare Trustees Report, but were afraid to ask. We're not letting anybody out of the room until you can repeat what's on page 356. The Trustees Report is, as the people in the room and the people in the audience online well know, is an important indicator of the Medicare program's fiscal health. We're going to be discussing that, starting off with Paul Spitalnik, the Chief Actuary for Medicare and Medicaid. And I suppose, in a sense, you're also the Chief Actuary for the whole rest of the health sector, since now the Centers for Medicare and Medicaid Services is truly the Healthcare Financing Administration.
My title is Chief Actuary for CMS.
Okay.
I haven't graduated to the entire health sector. Yeah.
It's only a matter of time. And let me just quickly introduce the other panelists. The next person in line is Stu Gutterman, who, just to clarify, on our website, we didn't quite catch up with Stu's latest position. He, I guess in the last few weeks, stepped down from the Commonwealth Fund, where he was a senior program director, but he is now senior scholar in residence at Academy Health. But he has a very, very long, one might even say sordid history in the Medicare program. We worked together for many, many years. So I guess I'm an unindicted co-conspirator. And then finally, Keith Fontenot. Keith is Managing Director for Public Policy and Government Relations at Hooper, Lundy, and Bookman. He's a visiting scholar at the Brookings Institution. But if there's anybody guilty here about Medicare, it's him, because he spent many years at the Office of Management and Budget controlling or not controlling every detail of the Medicare program. And with that, Paul, please take it away.
Thank you. Welcome, everybody. I'm going to talk a little bit about the overview of the financial status of the Medicare program. We released the trustees released their annual report yesterday to Congress. And just to jump to the end, there is no page 356. There's not even 260 pages in this report. Not even.
259.
Yeah, 259. Isn't that what I said? Not 260? So just to walk through my remarks today, I'm going to take a current snapshot and a brief evolution of the program, go through the formal evaluation of the financial status of the trust funds. We'll talk about the effects of MACRA, the Medicare and Medicaid, the Medicare and CHIP Reauthorization Act of 2015 that had a pretty significant effect on the projections in this year's report. And we'll also just end with a 2016 premium issue that's got a little bit of attention. I'll explain in a little bit of detail. So this is just an overview. I bring this everywhere I go. Just a little bit of background about the programs. Medicare is split into two major programs. There's two different trust funds, the Hospital Insurance Trust Fund and the Supplementary Medical Insurance Trust Fund, the HI and SMI. There's very different benefits that are paid from these different trust funds, and there's very different funding for these different trust funds, and so they need to be evaluated very differently. Most Medicare beneficiaries are participating in both of these trust funds. There's 54 million in HI, or Part A, 49 million in Part B, and 41 million in Part D, the prescription drug account. So this provides a brief summary of what the benefits are. On the Part A side, most of the hospital coverage, skilled nursing facility, skilled nursing care, and some home health, as well as hospice. On the Part B is the physician, outpatient, and some of the other more testing type of services, as well as a separate account is Part D, the prescription drug benefits. The financing for HI is through payroll taxes. Both workers and employers each pay 1.45% of earnings, and there's also an additional amount paid for high-income workers, as well as another source of revenue into the trust fund is some taxes on Social Security benefits. On Part B, and we'll talk about this much later, it's funded primarily through premiums that are established each year. And those premiums that are paid for by beneficiaries are matched by general revenue transfers. More on that a little bit later. Part D is, premiums are also established, and there are general revenue transfers as well, but those are established through a competitive bidding process each year. So this is just a high level looking at what happened in 2014 and compares what the expectations were, what would actually happen in 2015 to what the expectations were in 2014. On the HI side, the expenditures were actually pretty close. 0.2 billion out of 269 billion. We call that close enough. On the income side, there was more payroll taxes earned there, and that was slightly due to some anomalies in how some reconciliations were happen with respect to tax returns after the fact. Looking at Part B, here expenditures were higher than expected, and we'll talk a little bit about that a little bit later as well. On the Part D side, income and expenditures were fairly close to what was expected. They were actually came in a little bit lower. This is due to some pretty much timing issues. There was slightly fewer beneficiaries and slightly lower payments for particular types of benefits. But the way that the financing works on the Part D side is that a lot of what actually happens in 2014, the reconciliation for that doesn't happen until some point in 2015, and that's going to be happening in the next month or two. As many of you know, there was a pretty large increase in spending for particular specialty drugs in 2014, particularly those that treat hepatitis C conditions. And so we are expecting that there's going to be some significant reconciliation payments on back to Part D plans for the 2014 experience coming through in 2015. So this picture doesn't really tell the story. So this just looks at a long-range picture of how the benefits get financed, and takes a little picture of how growth is going to be evolving over time. So the different sources of income starts at the bottom with the payroll taxes. That's the 1.45% for both workers and their employers, and it rises a little bit over time because of the effects of some of those higher income contributions that will come in later on as the indexing doesn't keep up with wage growth. There's also the tax on OASDI benefits, premiums matching the growth in general revenue transfers for the most part. You could also see that state transfers and drug fees, that increases a little bit over time. And that's largely due to Part D growth growing at a faster rate than the rest of the program. And the top line there is deficits. So those are the amounts that often get alluded to or get suggested by the fact that there's a depletion date in the Medicare, in the HI trust fund. The fact that the fund's going to be depleted or projected to be depleted in 2030 gets a lot of attention. What gets less attention is that in order to provide benefits at some point thereafter, there's going to have to be reliance on this deficit spending. That's basically where the outgoes are greater than the income. And we'll talk a little bit about that as we talk about the HI status. And so I just like to put this up to show how the program has evolved over time. So you can see that in 1974 we were at 0.81% of GDP in the Medicare program, and the program was mostly an inpatient, a hospital program. And you can see the evolution of that program over time, and it's grown to include more services. It's grown to include a greater distribution of how care gets delivered, and just reflects how how care is delivered differently in 2014 than it was throughout the history and the evolution of the program. In particular, you can notice that the largest share of Medicare spending in 2014 is for managed care. And you can see that here in terms of the proportion of Medicare spending in private plans. And where, for most of the history of the program, there's been a modest level of spending in MA, and there's been some ebbs and flows. But you can see that the trajectory has been pretty well straight up, pretty much since the passage of the MMA, Medicare Modernization Act, in 2003. So we'll turn to the formal status of the programs. We'll start with HI. The question there, as I mentioned earlier, the funding is very different, so we have to evaluate the financial status differently. So are the assets plus projected income adequate to finance anticipated benefit costs? On the SMI side, where the funds are, where revenues are established on an annual basis, you have to take a little different look at it. And so just what's the nature of those future expenditures, how they align to the spending of the health economy, how they align with the spending of the national budget, and for beneficiaries, the portion of their income or their Social Security benefits. And so the fact that the financing for Part B and Part D gets set annually, there's really no long-term solvency issues. There certainly are long-term financial issues. So we'll start with just looking at the short-range projections on HI. And you can see that we've had a number of years where the solid line there was higher than the dotted line. Most notably, the effects of the recession greatly reduced the amounts of income coming in through the payroll taxes, and we were running deficits for a number of years there. As the economy rebounds and those income rates start to come back to where they would have otherwise been projected to be, we're expecting pretty modest levels of surpluses for the next several years. At the point where those lines cross, which is certainly in this short-range period, there is no turning back. The projections are that there will be deficits for all years thereafter. And so this is what happens to the trust fund. This is the trust fund ratio, which is the assets as the beginning of the year as a percentage of the annual expenditures for that particular year. And you can see that this is bounced around a fair amount, but the concluding story and what usually gets most of the headlines is that the trust fund is projected to be depleted in 2030. This is the same year as estimated in last year's trustees report, and in response to that, there's very little attention paid to most of the Medicare finances in this year's report, because that usually gets the most attention. But it's probably not the most important piece of information. So this is more informative, and this is really the present value of income less the present value of future costs. And you could see that in comparing what the results are from this year's report, there certainly is an improvement in the actuarial balance, or the actuarial deficit. Income rates usually don't change much year to year, but I did mention that there was slightly more income in 2014, and that translates a little bit into this higher income rate, but you can see that doesn't have a material difference. On the cost rate side, there is a sizable reduction in what future costs are going to be, and we'll talk about the reasons for that in the next slide. But basically, the actuarial deficit, this 0.87% of taxable payroll in 2014 report, has been reduced to 0.68% of taxable payroll. Said another way, the program needs an additional 0.68% of revenue across all sources. It doesn't translate exactly to 0.68% in additional the payroll taxes don't need to go up by exactly that amount. It's a little bit different than that, but that's a rough order of magnitude of what the effects might be in order to make the program solvent for 75 years. So looking at what, the different pieces, and you can see the pieces are broken out pretty significantly from the 0.87% down to from the deficit of 0.87% in last year's report to the deficit of 0.68% in this report. There's lots of different pieces here. The valuation period, we have one additional year. In our 75 years, we're replacing a relatively low-cost year with a relatively high-cost year, and so that has a negative effect. Base estimate, there's more data. The private health plan assumptions, this is that there's an assumption this year we are assuming that there's going to be more people in Medicare Advantage than we did in last year, and it does cost a little bit more to provide coverage for beneficiaries in Medicare Advantage than it does for beneficiaries in fee-for-service. Hospital assumptions were increased a little bit, and that's just some pretty near-term estimates for how some market baskets got calculated. Other provider assumptions on net didn't have much of an impact. The biggest piece leading to what the changes is this long-range cost growth assumption, and basically we did study the effects of effectively income technology on health spending, and we looked at that history, that relationship over history, and saw that there is a declining relationship, and so we've reflected that that nonlinear declining relationship, and the effect of that is we're effectively starting from a lower long-run growth rate assumption. So that long-range growth rate assumption starts in year 25. So we are lowering the year 25 growth rate assumption, but also the fact that it's nonlinear, we end up slightly higher than where we did last year. So we are starting in year 25 with a lower cost growth rate assumption, ending with a slightly higher. The net effect of that, the fact that there's much more years of that lower cost growth rate starting from year 25 than the effect of that long range, the very far out years, was that pretty sizable improvement in the trust fund balance. And so that's pretty much the walkthrough of what the effects are in the change in the actuarial balance from last year to this year. So this looks at the relationship of those income and cost rates over time. You can see that the income rate, the line on the bottom there, that generally stays pretty flat. It follows a pretty smooth trajectory. As I said, you can see that the 2.9% is payroll taxes. Everything above the 2.9% are those other sources, be it the tax on the high income earners or the tax on some Social Security benefits or OASDI benefits. You can also see that the cost rate is projected to increase somewhat over time. And in year 2030, under current law, when the trust fund is depleted, the trust fund would only be receiving enough income to pay the level of the amount of income that's actually coming in. In 2030, when the trust fund is depleted, the income in that year would actually be able to provide 86% of benefits. The corresponding number on the Social Security side is a little easier to wrap your head around. When that trust fund gets depleted and is able to provide 73% of benefits, or 79% of benefits, or 81% of benefits, depending on which fund you're looking at and which year. In a year where it can only provide 81 cents on the dollar, there's a couple of different options. You can either pay everyone 81 cents on the dollar, or you could delay certain benefits. So instead of paying a benefit in January, you might pay it in February, or some effects like that. In the Medicare context, it's a little more tricky to figure out what would happen in that situation. And I think the expectation is that lawmakers would respond far before, or just before, this situation might actually occur. Or this situation were to occur. And so really don't spend a lot of time thinking exactly what would happen here. But I think, as was highlighted yesterday by the trustees' remarks, the longer you wait, the closer you get to these points in time, the less options that are available and the more dramatic those options have to be. And so, once again, the trustees are encouraging of earlier action rather than delayed action. And we'll see what happens with that. But again, when the point I want to get across here is that when the trust fund gets depleted, it's not like Part A benefits would turn off completely. There still would be income coming into the trust fund, and there would be benefits being able to be paid. It's just not the full benefits, or not the full rate of benefits, or not all of the benefits. But it still is 80. In 2030, it's projected to be 86%. In 2089, the end of the long-range projection, it's still 84%. So comparing this year's results to last year's results, you could actually see the effect of those long-range assumptions that I mentioned. That in the early years, you can just barely see that the blue line is just below those black lines, and that suggests that our very near-term projections are up slightly, somewhat, on the Part A side. But in the long range, and this is where those changes in those long-range assumptions really started to accumulate, you could see the gap between the 2015 cost rate and the 2014 rate start to widen, and then towards the end of the period, it starts to narrow again. Or at least in the picture, you can see that it starts to level off. Now, the trustees continue to be concerned about some conditions under current law on the Part A side. I've been talking for a number of years, my predecessor has been talking for a number of years about some of the payment updates in the Affordable Care Act. And at the highest level, hospital and other providers will have their payment updates reduced by economy-wide productivity in all years in the future. We estimate that economy-wide productivity is about 1.1%. We think that the sectors that are actually going to get hit with that 1.1% economy-wide productivity can actually only achieve a health sector economy-wide health sector productivity growth of closer to 0.4%. That 0.7% represents something that might not be concerning on a one-year basis or a 5-year basis. But when you start accumulating it out over a number of years, it does become quite significant. In fact, payment rates get reduced quite considerably when you look many years out. And so what the trustees have been doing for a number of years has been also presenting what the cost would look like under an illustrative alternative. And that illustrative alternative maintains those the full productivity offsets for a number of years, but then transitions to that health sector productivity growth. And so you can see that at the end of this period, the cost rate growth would be considerably higher under the illustrative alternative. And that deficit of 0.68% would instead be, I should have wrote this on. Excuse me. I know the cost rate's 5.55% instead of the other one, so that's our cost rate. All right, well, we'll come back to it. I'll actually have some numbers in a minute to actually, but you can see that that's a sizable difference there. Turning to Part B, and you can see that the income and outgoes generally match. As I mentioned earlier, the financing is generally set on an annual basis, so the income generally matches pretty well. You can see that the black line is somewhat higher than the red line. The red line was what was projected in last year's report, so Part B spending is up somewhat, and this is really attributable across most services, and the fact is that most services are up somewhat. Nothing is up. Nothing is really dramatically increasing. The one thing that perhaps is increasing at a faster rate than everything else is outpatient services. But even that, when you kind of put it in context, isn't the lone driver for what this increase is. So the increase is pretty wide, pretty spread, but it's also not dramatic. So you look at the cost rates we have for 2014, 2015. And in fact, if you average them out over several years, we're still at very low cost rates. It's just that we're coming off of extremely low cost rates, cost growth rates, and those rates, certainly for 14, have increased somewhat. Looking at Part D, here you can actually see the effect of that, the effects of those hepatitis C, most notably the specialty cost drugs, did increase our projections. We do think that's going to have effects starting in 2015. You can see that pretty much is expected to continue throughout the projection period. And so if you put all that together, you could see that the SMI expenditures are expected to increase as a share of GDP over time. One thing you might notice here is that looking at the long range, Part B in particular, levels out and even starts decreasing as a percent of GDP over time. And I haven't yet spoken about MACRA, and I think it's about time we started talking about it. Medicare Access and Chip Reauthorization Act of 2015. I think it's actually very important to note, and I apologize for not mentioning this so far, that the 2014 report was based on an assumption that the sustainable growth rate formula, the SGR, was going to be overridden, just as it had been every year for the previous years it was supposed to take effect for the most part. And in fact, the trustees changed their methodology for what they were focused on presenting in the report to a projected baseline that specifically assumed that override. Earlier this year in April, MACRA was passed and has many provisions that affected Medicare, the most substantial of which was to the way physicians would get paid in future years. The SGR was permanently repealed, and so we don't have to have this dance of the SGR is about to expire and something's going to happen, and then something eventually happens, and everybody has to respond to it. The SGR is permanently repealed, so we don't have to worry about that anymore. The updates are specified for the remainder of 2015 to be 0.5%, as well as 0.5% for 2016 to 2019 annually. 0% in 2020 through 2025, but there's a provision I'll get to on the next slide that mostly offsets that. And then in 2026 and thereafter, the updates are 0.75% or 0.25% annually, depending on which track a physician is going to participate in. So starting in 2019, physicians have to select to participate in either alternative payment model program, APMs, or a merit-based incentive payment system. And APMs would be eligible if you would be eligible for a bonus if providers received a substantial portion of revenue from an alternative payment model. It still has not been defined exactly what a substantial portion is and what exactly how everything's going to get defined, and that'll evolve over the next several years through rulemaking. But for those physicians that are in this track, they would get a lump sum of 5% of their fee schedule paid in the following year. So they're not getting an update, but starting in 2019, they would get a 5% bump to the extent that they were participating and met the requirements. And similarly, starting in 2026, they would get the higher annual update, the 0.75% as compared to the 0.25% in the MIPS. So in the MIPS, the merit-based incentive payment system, providers are going to get either positive or negative performance adjustments based on their performance. The basic adjustments are assumed will be budget neutral. So on net, the average provider is going to get paid on average. The higher performers are going to get paid at a higher payment rate than that average, and the lower performers will get paid less. In addition, for 2019 through 2024, those years where there's no updates, there's a pool of $500 million that will be available for those that have exceptional performance. And so there is additional monies going into the program in those years. It's just focused exclusively on those exceptional performers. And again, that hasn't been defined yet. That'll be defined over time. And I did mention after 2026, they will be getting that lower update, the 0.25%. And so when we look at this and see that 0.75% over time versus 0.25% over time, our expectation is that providers will be in APMs as best they can. And so that's the assumptions, certainly the long-range assumptions in the report assume the 0.75% update starting in 2026 for providers. It is also important to note that in 2025, both that lump sum and that additional pool for exceptional performers goes away. And so there is a drop in payments for physicians in 2025. But on the longer range, the concern is that we have a similar, possibly a more extreme example of the concern we have around the productivity updates with respect to the hospitals on the hospital side. Our expectation is that the long-range Medicare Economic Index, MEI, is expected to is estimated to be 2.3%. And so basically the cost of providing physician services is expected to increase 2.3% each and every year. Payment rates are only going up by 0.75% each and every year. That gap is 1.55% each and every year. And so we have similar concerns as what we have on the hospital side. And in fact, it might even be more extreme on the physician payment side. It's in the long range. We'll get to a chart that will demonstrate that in a second. So the effects of that are that you compare the long-range Part B as a percentage GDP, you could see that expenditures in the long range, 2085, is projected to have gone down from 3.13% to 2.41%. In last year's projected baseline, long-range costs were assumed to eventually grow at the MEI of 2.3%. And you can see that this is a pretty dramatic reduction in what we expect Part B costs to be if current law were to be upheld, were to be followed. You could also see the 2014 that we did have slightly higher expenditures than projected. In Part D, you could see the same. Part D in the long range is not affected by these updates as that's a competitive program. So those effects really kind of contribute to this peculiar looking chart here where you could see the black line is the current law, and that starts off higher than what's both the red and the blue line. The red line is the projected baseline. The blue line is the prior report's current law. And you can see we start off higher, and then we cross the red line, and then we even cross the blue line. And what that suggests is that payment rates under this new system put in place by MACRA are expected to be lower than the rates that would have been paid under the SGR. We actually think that they're going to cross over in 2048, that starting in 2048, payment rates to physicians would be lower than what they would have been under the SGR formula. And the SGR formula, I think we all know, had its own problems. And so we're not talking about that big of a problem, but in the long range, we're talking about a much bigger problem. And so that kind of follows through with putting all those pieces together. Current law, the long range is expected to tap out at 6% of GDP. But putting together the illustrative alternative in this year's report includes both pieces, includes both the productivity cuts on the hospital side and most other providers, non-physician providers, being phased out over time. And the illustrative alternative also assumes that physician payments will transition from what they are at the end of the short range period, 2024, to the MEI over time. And under those scenarios, the percent of GDP is up to 9.1%. And so you can see that there's a very different story in the very long range, depending on whether or not these current payment systems can sustain in the future. And if that wasn't enough, there's one little issue in 2016 about Part B premiums. So there's not expected. The trustees' assumptions are that there will not be a cost of living adjustment in 2016. You put that together, there's also a hold harmless provision that prevents most Social Security checks from declining one year to the next. And that calculation includes the effects of Medicare Part B premium. And so there's, the fact that their Social Security checks aren't going up, about 70% of beneficiaries would be expected to pay the 2015 premium of $104.90. As I mentioned earlier, the Part B experience for 2014 and 2015 were a little bit worse than expected. And so not only would we expect general cost growth to have to increase that Part B premium, but we would actually have to return those asset levels back to the more historical level that would allow them to continue to pay claims. The only way that monies get into the Part B trust fund is how the Part B premium gets set. That Part B premium determines the premium revenue that's coming in, as well as the general revenue that gets matched based on that premium level. And so in order to get both the cost piece and the margin piece to build up the assets that were drawn down during the slightly adverse experience for 2014, 2015, we would have to increase the 30% of the individuals, and those 30% that aren't affected by the hold harmless provision includes dual beneficiaries. Dual beneficiaries generally have their Part B premium paid for by Medicaid, and so that would be a state burden and an additional federal burden. New enrollees, so newly joining Medicare, high-income beneficiaries, those that are subjected to the income-related premium amounts, or other beneficiaries that pay their Part B premiums directly to Medicare, that don't have their premiums withdrawn, deducted from either Social Security or their other federal checks. So in order to make up the difference for what we can't collect from the 70% that are still paying the $104.90, the 2016 premium is estimated to be $159.30. It's about a 52% increase. There is an expectation that there will be a cost of living adjustment in 2017, and at that point, most beneficiaries would converge back to paying the basic premium of $120.70 in 2017. We'll also note that the 2016 premium also affects the deductibles paid by all. That's also set by this actuarial rate that determines what the premium level is. And so there will be this spike and drop down on the deductible level as well. So we're expected to go from $147 as the Part B deductible in 2015 up to $223 in 2016, and it to then drop back down and return to a more stable level at $169 in 2017. Want to make sure it's perfectly clear that this is not what the premium is. The premium doesn't get announced until the fall. The Secretary of HHS will announce the premium usually in October, and at the meeting yesterday, when asked a question about this, she responded that they have, or the representatives mentioned that there are policy options that are being under consideration, and so we'll see what the Secretary ultimately decides. But this, the effects of the hold harmless provision are expected to at least play some pretty significant effect on the Part B premium that will be paid for by a number of beneficiaries next year. That is all I have.
Well, thank you, Paul, and it was great to end on that very positive note. This proves once again just how easy the Medicare program is to understand for the average consumer. I mean, my relatives would say, "Yeah, that makes sense." Of course, they'd be drinking. Stu, take it away.
Okay. Thanks, Joe, and thanks to Paul and the folks at OACT. I had the pleasure of working with them in my years at HCFA and CMS, and sometimes wrestling with them in the Office of Research, Development, and Information, which was kind of the predecessor of the Innovation Center without any of the tools that the Innovation Center has. The question that always arises when people talk about the trustees report is basically is Medicare doomed? I find over time that that question becomes more and more important to me as I start to flinch at the word. When I was younger, the word senior in a job title really was a positive thing, and now as I have stopped referring to old friends and started referring to friends of long standing, it kind of means something different. It is, but let me try and put things in a somewhat more positive perspective on this. For one thing, it is true that Medicare is inexorably going to account for a higher proportion of GDP over time. But let's think about that. We have, as a society, decided to produce more elderly people because we're living longer. I don't think we want to back away from that decision, and that means that a higher proportion of the population is going to be elderly than it was before. So it makes perfect sense for us to look at GDP and say we're allocating more of our resources to older people. So that's now clearly there are some issues here, but again, even that I think when I see these, I mean, the trustees report every year kind of puts up a warning sign. It basically says, if things proceed as we think they may, that we're in trouble unless we do something. And it's kind of like, when you're driving on a country road and you come to a sign that shows that the road is going to veer to the left, and ahead of you is a cliff that kind of represents, kind of plunging into oblivion. The reaction that most of us have when we see a sign like that is to say, well, I better, take the steering wheel and turn it in a direction I need to turn it so that I don't plunge ahead. And unless your mother-in-law happens to be in the car, screaming, oh my God, we're going to go over the cliff. It's a pretty calm situation. You just need to take control and kind of react accordingly to the situation. And I look at the situation with Medicare the same way. And if it's a really neat graph. If you've ever seen the graph of the roller coaster of showing the years, projected years to insolvency of the HI Trust Fund over time, it really is a roller coaster kind of thing. We come very close. I remember back in 1983, when the Social Security Amendments of '83 were passed, I think the projected insolvency was 4 years in the future at the time. And then, of course, it got pushed back. And generally over history, it's been pushed back by payment policies that basically represent, cuts in provider payments. But there are other ways to do these things. So it's not like we're in the backseat of a car with nobody driving. The question is how much we think we know about what way to turn the steering wheel, and how much we trust the person or the people whose hands are on the steering wheel. And that's, I think that's the important thing. Another, I guess, a really distinct illustration of that phenomenon is back in 1988, when Congress was considering the Omnibus Budget Reconciliation Act of 1988, which, of course, I must have studied about in 5th grade because I was much too young to be involved in policy then. But I remember there was a projection made that was released by the American Hospital Association that said that if OBRA 88 was passed with the payment adjustments that were embedded in that within 5 years, the budget window used to be 5 years rather than 10 for the Congressional Budget Office, that hospitals' Medicare margins would end up by 1993 being minus 49%. And that number encouraged both alarm in some supporters and laughter in others because it was a patently ridiculous outcome. And people criticized the projection, but it actually was a totally valid projection. It said this is what's going to happen if hospital costs continue to rise at 8.5% to 9% a year as they were at the time. Well, OBRA 88 was passed. Hospital margins didn't drop to minus 49% because hospitals changed their behavior. And hospital cost growth slowed down considerably because of the policy changes that were made in OBRA 88. So when we think about the future that's projected for us, we have to understand that that's not a spectator sport. It's actually a trend that we have, hopefully, have some control over. And we need to think about not, oh my God, we're doomed. How can we jettison this program that's leading us to oblivion? But how can we fix this? And that, I think, has been happening with increasing frequency and intensity over time. And it's reflected in the changes between the projections that were made last year and the projections that are being made this year. And so what we need to think about is not, are we doomed, but what can we do to turn the wheel in the appropriate direction? And that, I think, also applies to the warnings that Paul raises about the productivity adjustments in the hospital updates and the changes that are implied and not particularly well defined in the macro legislation. These are adjustments that are supposed to reflect the fact that there's a lot going on to help change the healthcare delivery system and to make it more efficient. But the best way to get scoring on those changes is to take money out of the update in the legislation because it's much more difficult to get scoring on individual actions that are intended to help the healthcare system be more productive. So the easiest thing to do is to say we're going to take a productivity adjustment out of the update. It's not really a prediction that that productivity is going to increase. It's an assertion that we have a right to expect that the healthcare sector is going to increase its productivity. So let me take a couple minutes to talk about some of the ongoing challenges specifically that Medicare faces and some of the things that might be done. Obviously, rising expenditures is an issue. There's an increase in the number of Medicare beneficiaries as the baby boomers retire, and a decrease in the number of workers per beneficiary. And that needs to be reflected in how we finance the Medicare program. So I suggest we need to think about in the long term how that program's financed and have it fit better the circumstances in which it operates. One thing, for instance, is that the Medicare tax, payroll tax, hasn't changed. The rate hasn't changed for years, as the situation that it's trying to fund has changed substantially. Medicare has been trying, but it needs to continue to try to be better in dealing with chronic illness because Medicare was designed as an acute care program, and increasingly it's becoming a program where with beneficiaries who suffer from multiple chronic illnesses. In fact, we've managed to turn some things that used to be fatal illnesses into chronic illnesses. And again, that's not a bad thing. That's a good thing. We just need to figure out how to deal with that. Medicare, as it was illustrated by Paul's detailed description of how the Medicare program is set up, it's a very fragmented program. You've got a typical Medicare beneficiary enrolled in Part A for hospital insurance and other facility-based services, Part B for physician and outpatient, Part D for prescription drugs, and most beneficiaries have some supplemental coverage that they get from yet another source. And that presents problems in several ways. One is it's certainly not a model for efficient provision of health care coverage for a population that really needs that kind interaction. It's also not a model for good coordination of care across different settings, because you've got different financing mechanisms and different programs with different rules and different deductibles and different copays. That doesn't encourage providers to talk to each other, and it doesn't encourage a kind of whole patient view of healthcare delivery. We've got coverage gaps. Medicare now is just about alone compared to private insurance in terms of not having a limit on out-of-pocket costs for Medicare beneficiaries. In fact, Congress recently imposed such a requirement for such a limit in the Medicare Advantage program, but not in traditional Medicare. And similarly, of course, all of us, what really scares me about growing old is long-term care and the possibility you may end up in a nursing home, and Medicare doesn't cover that at all. And another thing, I mentioned Medicare Advantage. There is an increasing controversy about what the proper balance is between traditional Medicare and private Medicare Advantage plans. A growing number of beneficiaries have enrolled in Medicare Advantage plans, and the phenomenon is particularly intense among new Medicare enrollees. A very high percentage of new Medicare enrollees is enrolling Medicare Advantage plans. But there's not really a good sense of how to best balance those two programs to bring out the best in both for Medicare beneficiaries, and I think that's a challenge that we face in the future. So those are the challenges. Those are the, if I can improperly apply my previous analogy, those are the steering wheels that we can grab, and we need to think about, not the fact that if we don't steer the wheel, we're going to end up in oblivion, but rather how do we steer the wheel, and what ways do we steer this program to make it effective for Medicare beneficiaries in the future. Thanks.
Thanks, Stu. That wasn't that upbeat either. Okay.
Well, thank you very much. First, thanks to Joe and AEI. I think giving everybody the opportunity to get down into the weeds of some of these numbers and to have Paul here personally to talk about it is a great thing to do. So thank you. But my real thanks are to Paul and his crew. And I had the pleasure of working with both Paul and his office, the Office of the Actuary at the Social Security Administration over a period of about 30 years. I can tell you, you will not find a harder working, smarter bunch of people in all of government. First, they're almost all PhDs in math. In spite of this, they do have personalities. They're funny. They're nice people. They're great to work with. But don't think that this report is all they do either. They have a laundry list of responsibilities that are extraordinarily critical to the operation of the Medicare program. So thank you and all your staff for all you do. I don't think we should take for granted either that the value of having a transparency function like this that gives us some independent thinking on what's happening with an absolutely major and critical component of our nation's social welfare system and our economy. So that's a great thing. I'd like to make about 4 or 5 sort of basic points and pick up on some of the things that Stuart was saying here. The first one of these programs are just, particularly Medicare, is just central to both the welfare of our senior citizens and to the nation's economy in many ways. I mean, this is a very large and very important program. I think by the end of the 10 years out, we're at about 75 million people or so in Medicare. That's a very, very important component of what happens with the elderly and disabled in this country. And it's a huge share of the economy. The second thing I would say is that the good news in this report in many ways is that nothing's gotten worse. The long-range changes, while they're relatively significant, are really methodological in nature and I think wise and reasonable. And so the fact that that we have some warning signs on a couple of things is good, but it's worth stepping back for just a moment and remembering that not only was, just a few years ago we were projecting that the trust fund would go run out of funds in a very short period of time, and now it's extended to 2030. If you go back a little further into the 2000s, I believe that actuarial deficit that Paul talked about was a multiple of the number it is now, probably on the order of 4 or 5 times larger. I think it was in the 2.5%, 3.5% range, something like that. I don't remember the exact numbers, but that whole was huge, and the entire program was projected to double from basically the projections now are that it tops out at about 6% of GDP. It was projected to top out at around 12, 13% of GDP. Paul, I always get nervous doing the numbers in front of the actuary, but so please correct me if I'm wrong. He's done it plenty of times before. That's a pretty startling difference from where we were 10 years ago. It really is. And we should be glad about that. I think that's a major, important improvement over time. But that leads to my third point, which is, these are enormous positive changes compared to we've been a few years ago, and that's great. But nor is it the time to rest on our laurels. We have an incredible opportunity to look at some of the issues that Stuart raised about, moving this thing from a program of acute care to a program of chronic care. But I want to highlight just a couple of things. When you look at these numbers, they look a little sterile and a little antiseptic. But if you take this concept of deficit as a percent of taxable payroll, first, this only applies to HI, so it's only one component of the program. And second, what the number 0.68 means is a little hard to just Paul alluded to kind of get your head around. So I did a little math. I pulled some of Paul's, and again, this makes me nervous doing this in front of the actuary, but so I pulled some of this backup spreadsheet. So taxable payroll is now somewhere around $8 trillion. Is that right, Paul? $10 trillion. So 0.68, which is 0.0068 times 8 trillion, is still a large number. Okay, and that would be about 50 billion, between 50 and 60 billion dollars, and that is the amount of money you would need starting now, kind of on a basis that grew along with the program over time to take care of the HI issue. Did I do that okay, Paul? Roughly? Okay, good. So my point is, that's not a small number. Okay, so don't let the sterility of a 0.68 or a 0.87 sort of mislead you. The second thing is that we tend to talk more about the HI issue because there's a simple, easy statistic that summarizes it called the insolvency date. But it doesn't really talk about, and Paul did a nice job of sort of characterizing the SMI, or the Supplementary Medical Insurance Fund issue, which is that because it is solvent by definition as a trust fund because it has premiums and general revenue funding. So it's there. There's a lot of issues to manage that. Paul alluded to the premium issue, which is a scenario we've gotten into before when inflation was very low. But in the very long run, there's a little table in the back of the actuary's report that shows the SMI claim on the general fund. And it shows the cost of the general fund payments to SMI rising to about 25% of corporate and individual income tax revenue. So when you get to this, and they've really done a nice job, and I worked with Paul's predecessor on this a great deal, of trying to characterize the importance and the relevance of this to the overall federal budgetary situation. Fortunately, there's not just an easy stat like the 2030. And I agree with Paul. I think people tend to make too much of that as a measure of what the program is, that program's health overall, partly because it fails to look at the details on SMI, and because it doesn't really tell you kind of the depth of the program over time. So it's a complicated picture. So while the trust fund exhaustion date doesn't tell you that, a good measure of health of overall, I don't think, it does tell you you have a little bit of time to get moving. And that leads me to sort of my next point. One of the reasons we sort of don't have a lot new here now is that we still don't yet really understand all of the things that are going on with respect to the slowdown in healthcare costs, and particularly in Medicare. So I'd love to get Paul's and my colleagues' take on that one. There's good reason to believe that Medicare responds somewhat differently than the rest of the economy, right? The people there are generally a little more insulated in terms of income. They have a more dependable source called Social Security. The program itself hasn't changed structure that much in terms of deductibles and the like. So what's going on there is, to me, is pretty fundamental. And so the real question is, and my colleague Louise Shaner pointed this out to me yesterday, is is what's driving down cost good things? Or not always good things, okay? So availability of new life-saving technologies may have been a cost-increasing factor over time, but is the lack of availability of these things a good thing societally, even beyond the Medicare program? And so I'm very curious to get everybody's thoughts on that one. I don't have an answer, to be candid with you. fourth point, or fifth point, that there are some questions and discussions at the press conference on, and Stuart raised this point, about the various delivery system reforms and their role. And I should tell you, and Secretary Burwell pointed this out yesterday, Paul plays an exceedingly critical role in assessing the performance of this, which is what you would always want an actuary to do. But there's two rules to this. I think people tend to think about this as just saving Medicare a lot more money. And that may be one rule, but the other rule is to help do what Paul so helpfully elucidated, which is to help providers grow in productivity so that they can live with the numbers that are projected and the baselines that are developed for them. And I actually think this is a really salutary thing, that people are focused on this, and that it's and that it's a regular example. I don't believe in one solution will fix Medicare forever kinds of ways of looking at the world. I think it's much more likely to be a set of incremental changes over time as we figure out how to increase efficiency in the healthcare system and move forward. And my last point is I just wanted to give Paul a little shout out for his incredible bullseye on the assumption regarding the SGR update last year. If not, we would have maybe seen some different in-year swings in the numbers. But that was actually a great call. And I remember we talked about that last year, and it was not without its own degree of controversy. But you got the bullseye award on that one, Paul. So with that, thank you.
Thanks. Yeah, it's good to get the Bullseye Award rather than simply wearing the bullseye.
Right.
So I'm going to pick up on, actually, I'm going to try to weave together a little bit of the themes that Stu and Keith brought together. I like the car analogy, steering the car. But we have to keep in mind that policymakers are, and Stu alluded to this, I suppose, and Keith did especially, policymakers are not the sole steerers. In fact, I would suggest that they're probably not even the dominant steerers in the health sector for lots of reasons. They have less access to information. They have less ability to respond to the information they do get. And they're looking at things through the rearview mirror most of the time. I mean, this is not an insult, but the fact is that when we collect data from the past, not from the future. Now, I'm confident that the actuaries will figure out how to solve that problem. Right now, you have to make assumptions. And of course, the assumptions oftentimes are wrong in ways that you can't anticipate very well. So that's a real problem. I have to say that the one of the real contributions that the Actuary's Office has been making for quite a number of years is, and this is a shout out for this part of, or this adjunct to the report, but in recent years, there's been a memo produced that I think probably has the same title every year called Projected Medicare Expenditures Under an Illustrative Scenario with Alternative Payment Updates to Medicare Providers. And it's a very, very important document, and it's much shorter than the 369 pages or whatever the number is. An important point, which they make at the end of this document, is to say that, let's see, where is it? The current law projections, that is to say the projections that are made in the formal trustees report, should not be interpreted as the most likely expectation of actual Medicare financial operations in the future, but rather as illustrations of the very favorable impact of permanently slower growth in healthcare costs, if such slower growth can be achieved. That's the single most important sentence, I think, in this adjunct report, but it may well be the single most important message that people should take away. If you do it, and even more importantly, if it works the way you think it's going to, and if the part you can't control, which is essentially the whole health sector's reaction, and not just providers and health plans, but also us darn consumers. If that works out great, well then, good for us. And if it doesn't, well, we've got to do something. Now, in that regard, the public trustees, they put out a short statement every year, and I found this sentence. I thought it was a good sentence. A critical unintended consequence of large trust fund balances has been that unavoidable corrective actions have been postponed. Now, they're talking about Social Security. Fortunately, Medicare doesn't have this problem. However, it doesn't mean that it's been any easier to take those unavoidable actions that, if taken, would maybe smooth the path to the future a little bit more. I mean, the fact is that as I think Paul alluded to, the human nature is such that we often put off the unpleasantness of making any changes until we absolutely have to, or a little bit later. And it's a little bit later. Why? Well, it's because we don't really believe that what happened actually happened and might not happen. It takes a while to really confirm that, and it takes an even longer time for the political process to generate enough political support to actually take changes that are difficult to accept, and not necessarily huge changes. Even small changes are very difficult to push through. So, it's a problem. Okay, so I want to diss another number here. We've all kind of taken pot shots at our favorite numbers, and one of my favorite numbers that I think is really not all that useful is something called dedicated revenue and the so-called unfunded liabilities of the Medicare program. This is yet another attempt that has been developed to try to get away from simply looking at the depletion date of HI and having a broader measure of, or broader indicator of Medicare's sort of long-term financial status. Dedicated revenue refers to the specific revenues that come in that are specifically collected for Medicare and do not include general revenue. So they include largely payroll tax revenue and premiums paid in Part B, and some people pay premiums for Part A and of course Part D as well. Those are the big items. And so fiscal conservatives will often say, well, we have this huge unfunded liability. Medicare doesn't have the money. The government doesn't have the money readily available to cover this huge unfunded liability, which this year over the next the estimate over the next 75 years is $28 trillion in present value terms. Okay, but if you look at it that way, then you're really implicitly assuming that the rest of the money is going to be easy to collect, no problem. And that's $27 trillion. It's going to be an issue, and it's going to be an issue for lots of reasons, but it's demographics and it's also economic. The demographics, of course, is that I think many of us in this room are baby boomers, and we're all going to get into the Medicare program, and by golly, we're going to live to 100, but we're going to spend a lot of money doing it. Thank you, young people. So we have that issue, but we also have a fundamental economic issue, which is that the baby boomers happen to be born largely in the right years. And the baby boomers enjoyed unprecedented economic growth in this country, unprecedented not just in this country, in the entire span of human history. So we're kind of used to good things, and it's easy. I know we tell our kids it's not that easy, but hey, compared to past generations, it's been easy, and we're used to that. Well, when you think, it's hard to generalize, but certainly when you think of young people who got out of school, say in 2007, and were looking for a job and didn't find one, their permanent income is, their income perspective is permanently lowered by that experience, because if you don't get that good first job, then you're kind of behind the curve. And there have been plenty of econometric studies that demonstrate that you don't want to be born in that generation. That's not to say that we're not going to have good, substantial economic growth in the future, but the reality is that the number of workers per retiree is going to drop. It was 5.4 workers per retiree in 1970. It dropped to 4.7 in the year 2000, and by 2030 it'll be 2.7. That's a pretty substantial drop, and so even with substantial economic growth, this is going to be an issue. So we're going to have to do something. Now, I agree that the health sector isn't going to just sit there. It's going to respond to reality. I think that some of the reality will be caused by policymakers in Washington. I think a lot of the reality will be caused by reality. And it's going to happen, that reality is going to strike well before you get to age 65. It's going to mainly strike the rest of the health market, which is a good thing, because the market below age 65, the market that is not dominated by Medicare and not dominated by Medicaid, is much more likely to respond to actions because they're less regulated. They have more flexibility to try things, find out if they fail, find out if they succeed, make adjustments. If they fail, drop them. If they succeed, try to perfect them. But don't stay with the same model year after year after year. And that's been a problem with the Medicare program in lots of ways. That's a problem with the initiatives that the Innovation Center is taking up, because there's, and this is not, again, it's not necessarily a criticism of the Innovation Center. It's just a reality about government. Once you set something, you're in a regulatory process. You set those regs up, it's very difficult to make adjustments. It's very difficult to really detect what's going on, and making changes are very, very difficult. Okay, so what are some, I want to end with a good negative note like everybody else, some threats to kind of the Medicare's financing situation, general threats in the healthcare sector. Well, so one of the threats from a financial standpoint is whether we're returning back to normal in terms of overall health spending. Now, keep in mind that when I say threat, I also mean good thing. As Keith said, spending money on the right stuff gives you the kinds of cures that we all hope for, and we're not good at having public conversations, national conversations about how much we want to spend, but certainly everybody would agree that a cure for Alzheimer's disease would be a very desirable thing, and then we would argue about the price. But we've had this remarkable period for the last, it's been really longer than since 2007, a slowdown in the growth in healthcare spending. But it seems like it's coming back. The Alterum Institute, which produces data a little bit faster than the actuaries, but I think the actuaries are also saying that we're beginning to come back as well. The Alterum Institute is saying that year over year, most recently, the increase has been about 6% rather than about 3% national health spending, which suggests that we're beginning to edge up to where we have been before. That can be a good thing, but of course it raises fiscal challenges. In terms of Medicare, that's a particularly impressive period of slow growth for lots of reasons that are somewhat mysterious. Certainly one of the reasons has to do with prescription drugs. The Part D program had a remarkably low rate of growth of spending, partly due to the forces of competition, partly due to the fact that some very important drugs, including Lipitor, went off patent, so there became availability of generics for some very, very popular drugs, and partly because new things just weren't coming on the market. Now, the competition was driving a lot of that shift to generics. If you didn't have the financial incentives, people would continue to say, oh, yeah, sure, give me that expensive one. It must be better. Turns out that when induced to do it because it might cost you more, you find out that that generic Lipitor works just as well as the brand name product, but the label isn't as fancy. So that's a good lesson for seniors and everybody else to learn. But there's an issue. We have the hepatitis C drugs. That's going to create a spike in spending on prescription drugs. There are these other things that are coming down the road that are going to contribute to this. What are we going to do about that? Well, I think the wrong thing is to say, well, gee, let's have the government negotiate those prices. Because when the government negotiates, what is it doing? It's not negotiating because it's too big to negotiate. It's setting the prices. You need to have alternative approaches. And you also need to realize that these things are not all that permanent. You need to rethink what we're doing. There are regulatory issues. There are other issues related to kind of the business behavior of pharmaceutical companies. But in the end, if you're going to have the government set the prices, then you've made a decision about how much prescription drug innovation you want to see in the future. The other issue, though, is that we have a tendency to ignore the fact that all of these different services kind of interact. Healthcare is a team sport, and prescription drugs are part of the team. So we have a tend to focus on the one thing that we don't like, because if we're a health plan, pick on them. But the reality is that you got doctors involved, and for many treatments, you've got hospitals involved, and you've got post-acute care. It all kind of works together. So the way to look at this is not let's pick the most expensive thing and let's go after it because that's what's going to solve our problem. Instead, you need a more holistic view of these things. This is one of the arguments for more comprehensive health plans. Unfortunately, the traditional Medicare program operates in a very disjointed fashion and cannot take that perspective. I can't say that every Medicare Advantage plan does that, but a number of them recognize that you have to look at the whole picture, you have to look at the whole patient, you have to take a longer perspective, and if you do that, you're likely to have more sensible policies that do a better job of balancing cost and what you want, which are the outcomes for patients. But we've got a long way to go there. Okay. Medicare Advantage. It's been fairly successful in spite of the ACA's attempts to cut back on spending in the Medicare Advantage program. We see substantial increase in enrollment over the last few years and will continue likely down the road. I think a big question in my mind, although before we started talking, Paul said, don't worry about it, but I'm going to worry anyway. Somewhere down the road, the baby boomers are going to get old enough and sick enough that they might think, well, gee, why do I want a somewhat restrictive plan when I could go back to traditional Medicare? Now, I'm not sure we should worry about it. I think Paul may well be right, because that's also a prediction on what traditional Medicare is going to look like in 10 or 15 years. We don't know what that is. That's going to be a function of policy making. We don't know what that's going to be, although we can be pretty confident it ain't going to happen this year. But it also depends on what happens with Medicare Advantage plans, and also it depends on what people have grown to expect. We always forget that it's the beneficiaries who get to choose. And one of the reasons I think that we're seeing a big spike in Medicare Advantage enrollment is because baby boomers expect comprehensive plans and they expect better deals, and they can see the difference. And so it may take a couple of years for them to experience traditional Medicare until they wake up and say, hey, wait a minute, why am I spending all this money to get this? When in fact, there's a plan in my neighborhood that gives me everything I want and it's cheaper and I get better benefits. But will that continue? That's a good question. So that's another issue to think about. And then maybe finally, will the payment reforms work? And in particular, will the aggressive indexing that the ACA has inserted in every corner of Medicare payment, and if ACA didn't do it, Micra did, for physicians, will that really go on? Now, the actuary's view is, and I think a reasonable view is, that those severe restrictions on increases in payment rates, which essentially affect all Medicare providers, that they're not likely to last, at least not forever. And that's partly because of the severe impact that they will have on, if nothing changes, on payment rates for physicians, for hospitals, post-acute care, you name it. But it's also because of the political aspect, which is that Congress has never been known to just let something like that let go. The fact is that to get the ACA passed, you needed to generate a good CBO score. It's passed. You don't need to generate a good CBO score anymore, not for the ACA. And we have now a precedent that you can pass a big reform of Medicare and not pay for it all. Medicare and other things, and not pay for it all. As a graduate of CBO, I'm a little worried about that. As a fiscal conservative, I'm a little worried about that. But the reality is that when the going gets tough, the politicians get going. They move away from the hot spot, and they will find a way around the problem, but it won't necessarily keep us on a fiscally sound path. Now, again, does the fiscally sound path lead us to a result we want is a good question. But nonetheless, I think that's a big issue. And then finally, last point, what is called Baumol disease, which basically is an assertion by a great economist from the 60s, I guess, or maybe the 70s, that healthcare can't possibly increase its productivity because, after all, it's labor intensive, and you just can't expect improvements. Really? Well, there are computers now, and if we get our act together, we could actually use the data that could be generated by electronic medical records to inform healthcare providers, health systems, and consumers about effective and ineffective treatments, about better ways of doing things and less good ways of doing things. We could move in rural areas, or for that matter, in all areas. We could move to systems of care that don't require exclusively expensive physician labor. You can have less skilled people running the machines. In fact, they do now, but you get to pay physicians for running the machines when somebody else is pressing the button. The fact is that technology works to improve productivity in healthcare just as much as it works to improve productivity everywhere else. So why hasn't it happened? And I think largely it's because of the financial and political incentives that discourage the kinds of adoption of efficient technologies and efficient approaches, and especially in the Medicare program, you've got a very traditional Medicare, you've got a very segmented program. Healthcare, as I said, is a team sport. Medicare treats it as if it was a bunch of individual providers, really not looking past their particular organ system. That's a real problem. I'm confident that we're going to move in a more in a smarter direction there, and I'm absolutely confident that Baumol disease should be relegated to the dustbins of history. It's based on a false assumption, at least when applied to healthcare, that has already been disproven. The problem is we haven't had the aggressive movement because of other issues, including the way we handle policy in this program. So with that, why don't we argue among ourselves for a few minutes and then open it up to the audience. Does anybody want to make a comment? Well, we'll start with.
Thanks. I just wanted to respond to a couple of points that. So first on the MA point, actually I'll start with where you ended up on the technology side. So there is a wealth of evidence that there has been technological developments and improvements. It's just obvious. There's been significant improvements in terms of how care has been delivered, in terms of what's capable, what's possible today, and what's as compared to what's been available in the past. All the evidence is that technology advancements have been cost increasing to date, as compared to cost reducing. And so typically when we think of productivity and we think of computers on our desktops, we've been able to produce more output at a lower price because we've been able to do more. The evidence in the healthcare system has been that we've been able to clearly do more, but it's also costing us a lot more. And so we are, where the productivity has likely manifested in the health sector over time has been in improved outcomes. Everyone alluded to this, that we are getting better treatment today. We are living longer. We are being able to treat diseases that we haven't been able to treat in the past. And that's largely due to technological developments. It's largely due to advances in the ability to do research, so some of the data that's been available. But the concern is that the way that prices get set and the way that payments get made aren't based on aren't outcomes based. And that's one of the drivers in terms of some of the innovation that some of the efforts of the policymakers have been trying to shift to, well, let's reward outcomes. Let's have payments be based not just on the volume of services but the effectiveness of services, and so that I think there's some attempt to transition there. The concern that we continue to raise in these reports is that when the measure of these successes is based on the old measure of how much output am I getting for these level of inputs, well, I'm paying more than I did last year, and I'm doing the same service, but it's costing me more. That's not a productivity gain. And so there's a lot of studies and a lot of research that have shown that, yes, perhaps on a quality adjusted basis, there's been substantial productivity improvements. However, when you look at a traditional measure of productivity, we're seeing either zero or even in some cases negative productivity in the health sector. The one other thing I just wanted to clarify on the MA side. So yes, the influx of baby boomers in the Medicare Advantage program is clearly affecting the influx of baby boomers is affecting not just the Medicare Advantage program, but it's affecting all of the aspects of the Medicare program. What we've seen, and it's somewhat surprising, I think when we looked at the data, we were expecting to see that those increases that we're seeing in managed care enrollment in the Medicare program, we expected to see a bubble around some of the new entrants, the younger Medicare beneficiaries. If you look at what those, I had that slide that had that graph going straight up, those increases are across all ages. It's at age 65. Yes, there's more now than we're enrolling in managed care than 10 years ago. But that's true at 75 and at 80 and at 85. What we've experienced is that there's just been a general prevalence for opting into managed care plans, and there are instances though where those that are enrolling out of the plan, they do tend to be the sicker beneficiaries that need the most care that need the most care and want the most options available to them, and so that's where we have seen that. And that was the concern that I was raising before, that the demographic shifts of who's in or who's out tends to be more risk-based or use-based rather than just purely age-based. Looking at it across ages, those increases have been pretty consistent across.
Just a couple of points on the issues that have been raised. I used the example of over 88 as showing how you could cut Medicare spending without having the demise of the healthcare delivery system. what we have to realize is that unlike the situation in over 88, which really was payment cuts, there's an awful lot going on. The Innovation Center represents a lot of activity to actually work with providers and help them figure out ways to increase productivity. So there's much more production going on in Medicare. I mean, much more effort being focused on slowing the underlying costs in the healthcare system. We talk about costs in healthcare in different ways. In this context, we talk about Medicare spending, and that's a dangerous confusion to talk about that as cost. I mean, that is cost to the federal government, but it's not cost to the healthcare system. The underlying cost of the healthcare system is what's going to end up spelling the success or failure of all of these policies, and so working on that is really important. So that's really a positive change. Another observation is that unlike many groups in society where there may be conflicts, when we talk about young people versus old people in the context of Medicare, the difference is that while if you're white, you're never going to be black, except for some folks who have been in the news lately. But if you're young, you're going to be old. So it's not an us versus them situation quite as much as I think it gets painted in Medicare. Young people are paying in, yes, it's directly going to pay for services that are being consumed now, but they're actually paying into a program that they hope to be able to benefit from when they get older. So that's I think a perspective we need to keep. And it's also not public versus private. If it is, then we are doomed. Public sector and the private sector have to work together to control healthcare costs. On the Altarum numbers that have come out, I seem to remember last year or the year before there was a release of a number that healthcare in 2014 was going to increase by 9%. By the early numbers, and it turned out not to have happened. Now, I'm not saying I don't know. I don't have a crystal ball. I don't know what healthcare spending is going to be, but I say let's wait before we decide that the current trend has ended and we're back into the old days of rapid healthcare spending growth. And then finally, the Medicare Advantage versus traditional Medicare. Medicare Advantage has been very successful, certainly, in enrolling more Medicare beneficiaries. If you look at the distributions of costs across Medicare Advantage plans versus traditional Medicare, you've got half the country where traditional Medicare is actually spending less per beneficiary than Medicare Advantage plans do. And as Joe mentioned, it really depends on the individual Medicare Advantage plans. There are some very, very good ones, but not everybody is. And again, we tend to hold them to a benchmark of traditional Medicare costs, which is not exactly the paragon of efficiency. So the fact that many Medicare Advantage plans are complaining because they don't think they can survive on the ACA cuts, which are cutting them basically to something based on traditional Medicare costs. You got to think about what that means in terms of their ability to manage costs. And finally, in terms of the way they pay providers, many Medicare Advantage plans, they take risk. But in fact, the question remains to be resolved how they pay their providers to pass on that risk. And that's really where it counts. The incentives count where the rubber meets the road, where the patient and the provider meet. And it's not clear that Medicare Advantage plans are paying any differently than traditional Medicare in terms of how they actually pay their providers.
So there was one thing I did want to really agree with, Joe, in your statement there, which was the role of these measures about present values and infinite horizons and things like that. I find these things very confusing, to be frank. For example, the closed group present value measure suggests that if we had no longer admitted anybody to Medicare, how much would we need in funds on hand to be able to finance the program? It's a traditional measure that's applicable in the private sector, but these programs are simply different. And the context is different. I think your point about policymaking in this world, I don't think these measures have really helped the policymaking in this world. I don't think there's any substitute for slogging through a lot of the numbers and the details that Paul has put up and trying to tie those back to the context that it's within, because Medicare is so large that it is part of the overall budget context, and you just can't escape that in many ways. The second question I would say on the issues of productivity, I don't think it's immediately clear that you can't have more productivity growth. And the good thing is that people, you and others, are paying an awful lot of attention to what's happening in these new payment models and in what's going on in the world. I had the pleasure last week of being out in a couple of hospital systems and watching what they're doing. And it's a challenge. I mean, they really are, but they are changing their focus to figure out, okay, how can we get costs out of the system? How can we get these people to talk to these people? That was not what hospitals and many of these institutions were originally built to do. So we're asking them to do new things and giving them new tools to do it, or trying to. And, it's we're kind of making it up as we go along a little bit, but I don't think there's another way to do that. I think Paul raised a good point with respect to the macro bill as well, which is that, in one measure, it sort of legislated kind of what had been going on in a lot of ways in terms of annual fixes. The updates aren't that rich, but it does put in place a mechanism by which the Secretary of Health and Human Services can make a lot of administrative determinations, and this is not this secretary, it's several secretaries probably over the next several years, that will continue to drive this question of, can we get more productivity out of the system? Can we improve quality in healthcare without, can we reduce costs without hurting quality? All the kinds of things that are there. And so what you've seen with CMMI with this is a delegation of authority to the executive, whoever that executive may be, over time, and we'll sort of see how that all plays out. But it's not going to be quick. It'll take years, I think. I did have one question, Paul. How many people do you assume that everybody moves to the APM? Is that your basic assumption, kind of underlying the?
Yeah, all physicians are assumed to ultimately be in the APMs. Yeah.
All positions ultimately in the APMs. Gotcha. That's pretty interesting.
So few quick comments. One of the, just on the so-called permanent doc fix, the sustainable growth rate mechanism, the important part of the mechanism, which is the update factor, didn't change. It just changed the number. And so, I agree with the actuary's report that basically says, 0.5% increase. The physician establishment will be back on Capitol Hill next spring saying we can't live with this, and that's just a permanent feature of life. No matter how much you give people, they can't live with it. It's too little. But that does seem like it hasn't resolved that part of the problem. On what we should assume going forward when you're making policy judgments, I would say it is not prudent to assume that things are going to be just great forever. I think it is prudent to assume that things will deteriorate and get ready for them. Now, the problem is human nature being what it is. We usually wait until long after they've deteriorated before we get ready for them, but what the heck. On productivity, I think the issue is precisely what do we want to buy? So it's really not this measurement stuff. It's what do we want to buy? And believe me, if Stu Gutterman is willing to pay for anything I want, I'll take it. That's the problem. And then finally, Medicare Advantage. If you look at, I think, virtually every report in the last 4 or 5 years from MedPAC, you'll see that Medicare Advantage plans bid below fee-for-service average. Certainly the most recent one says this. A large part of the problem is that the way we've just organized the way Medicare Advantage versus fee-for-service in the bidding process is just so utterly wrong. We're not really getting a competitive process there. And so maybe with that, let's see if people have some questions. Let's see. We have somebody with a microphone, and you're standing right there. Please identify yourself, and please ask a question rather than just give a statement.
I'm Julie Cantor-Weinberg, an independent health policy consultant. My question is on IPAB. I understand that the actuaries' estimates mean that IPAB will have to start doing its thing in 2017. IPAB has become a four-letter word in Washington. I've lost track of how many times it's been repealed in the House, but I wondered what your predictions were with regard to the IPAB.
So just on the technical side, the IPAB, there is no IPAB determination for 2015. That's the only thing that's required to be made in this year's report. We do forecast that in 2017 there will be an IPAB determination, which would require a proposal to be made in 2018 and to be implemented in 2019. Just working through those numbers, it's actually very slight, and so that the shift from what was assumed when the IPAB was assumed to kick in last year versus when it's assumed to kick in this year, it is a 5-year difference, but the actual movement in the numbers for what happened in 2017 was actually pretty modest. So I think we were roughly about 0.3% lower last year, and now we're 0.1% over. And so that's just the sequence of events, and I'll leave it to others to debate what do they think will actually happen there.
Well, it's true that IPAB has become a four-letter word, and I just keep thinking of a grammar school teacher I had once who said that if you use four-letter words, what you really ought to do is take a step back and think about what it is you're really trying to say. And I think that applies to IPAB as well. The way it's legislated, it's easy to hate. But if we think about what a real independent payment advisory board could do in terms of recommending real policies, not just across the board slashes in payment, but real policies that help to achieve the goals of the healthcare system, I think it can be a very productive thing. And also there's tendency to view IPAB as 15 pointy-headed bureaucrats locked up in a room and coming out with tablets, which are the policies that Congress then gets rammed down its throat. But there's nothing in the law that says that the process has to work that way. In fact, one would expect that the members of IPAB would have public meetings and would consult with members of Congress and other policymakers and other stakeholders and try to come up with policies that actually work. If it doesn't work that way, then it's not going to work. Right now, it doesn't exist, so it may never have the chance to prove whether it can work or not. But I think there is potential in that kind of mechanism to try to focus on changes that need to be made. But again, as Joe said, there have been previous instances of legislation that focused on this issue that never came to fruition because folks backed away from the tough decisions.
Yeah, that one other thing, you don't need the IPAB. Because what the law says is that if the IPAB doesn't exist, the secretary shall do these things. And interestingly enough, that's what the secretary is supposed to do, for Pete's sakes. Anyway, let's see. Maybe over here, and then we'll kind of work our way around the room.
Thank you. Paul Heldman with Potomac Research Group. As you panel probably knows, CMS, or the administration, recently proposed a pretty significant bundling initiative that's going to cover episodes of care for hospitals and post-acute care in a large area of reimbursement, hip and knee replacements. I'm wondering what you think about the potential for that to save money. And if you think it does have potential to save money, where is the savings going to come from? The device side, post-acute side, hospital side?
Well, we certainly worked with the administration in terms of doing the pricing of that. I don't recall exactly what our score of that particular initiative was. But when you do put together these pieces and develop what the bundle payment is, typically you are, adding up all the different component pieces that you're putting together, and then you may or may not apply a savings target to that. So I suspect that's exactly what happened there, and could certainly get you more information.
Mark McCarty with Medical Device Daily. One of the things that one tends to assume about IPAB is that it may reach for a large lever, however destructive or not you might think it is, and so you have to wonder if least costly alternative might sort of pop back up. I'm under the impression that LCA is dead as of Hayes v. Sebelius and Hayes v. Levitt. Drawing a lot of blank stares. All right.
Well, nobody's talking about it now. We're running out of time. I don't think we have a good answer for that. Let's go on to the next question. Come this way. There's a lady there.
Hi, Julie Summers from MedPAC. Paul, you mentioned the long-range cost growth assumptions and that they've changed from 2014 to the 2015 report, and that led to sizable improvement in the trust fund balance. And I was just wondering if you could explain a little more about that change. You said something about changing to a nonlinear assumption. I didn't know how much it was a technical change versus impacted by the slow growth we've seen in the past.
The change in the long-range assumptions was purely a technical change. It was a methodological change, and basically we looked at the past relationship between health spending and income growth and saw that that relationship was changing over time. And so as we applied that in our long-range forecast, we are more directly modeling what we were experiencing in that experience.
John Green, National Association of Health Underwriters. So I'm interested in this discussion about productivity. What about the productivity within Medicare? Like, for example, with respect to program integrity, are administrative costs sufficient to manage this, this very muscular, as you said, economic driver in our economy? They always talk about the 2%. And the GAO report yesterday was very, very troubling around program integrity. What about productivity within and to save dollars and use those dollars? Because before, Stu, you asked for more increases in taxes. I think that we have an expectation as a society that the program is being run efficiently.
I'll just start on the program and integrity part, and I'll pass it over. But there's certainly evidence that there is a very high return on program integrity dollars that are spent in the Medicare program. If your question is, would additional dollars result in additional returns, the answer is probably yes. There is a budget process, and each group gets funded, through that process. And Keith can probably speak a little more expertly on exactly how that process works or doesn't. But there's certainly evidence that there's been a very high level of return on program integrity dollars that has been spent to date.
If I can, I totally didn't mean to imply that we should be copacetic about the level of whatever level of spending happens to develop. But I was reacting to statements that essentially imply that we can't afford to have more elderly people in our society. Yes, we need to do everything we can to make sure that spending is efficient, and that is true both at the program level and at the healthcare delivery level. Just as people back away from tough decisions on healthcare delivery changes, they also tend to back away from tough decisions in terms of putting resources into efforts like program integrity that really do have a very high return in terms of the program, and also in terms of beneficiaries, because it's better for beneficiaries if Medicare money is being spent in a productive way.
Yes, I think it's so. A couple of points here. First, we were operating on a set of discretionary caps over the next several years that are at historically extremely low levels. So the discretionary side of the budget, which is NIH, FDA, CMS admin expenses, with an exception I'll talk about in a minute, is pretty constrained, and it will have real effects. And the NIH people can explain this to you in great detail. I mean, that's crimped their new research efforts mightily. In the case of program integrity, there is a separate little mechanism, what's known as a cap adjustment. Boy, this is getting in the weeds. But basically, it lets you add money on top of what is done in the base if you, if you do certain things with the money that you have in the base. In other words, if you maintain that money, you can add a certain amount. It took several years. I mean, this was put in place probably back in 2009 or something like that. I think we got it for 1 year and then did not get it for several years, and I think they appropriated it last year. Did they appropriate the add-on amount? I think it's in the current bills, at least as I saw. Now, I think you're right that it's important that the public know and perceive that that's being done well by CMS. There is a point at which you can overstep it too, and and get to the point where you're sort of impeding some of what goes on in the provider operation. But I think in no case are you going to find that this is going to fill the gaps that Paul has identified in terms of financing. Okay, it's important to do for many reasons, which you alluded to. People have a right to believe that their dollars and to know that their dollars are being spent wisely, but it's not going to. This is not going to fill the financing hole that Paul's described.
Hi, Joel Zinberg. I'm a practicing surgeon and a visiting scholar here at AEI. The healthcare system, both in and out of Medicare, is moving in a tremendous change from its traditional fee-for-service into these alternative payment models. But the early results on the alternative payment models, things like the ACOs and other similar experiments, have been less than exciting in terms of money saved. You also have a lot of providers have been unable or unwilling to participate or move into these payment models. How much of your forecasts are predicated on the healthcare system, particularly Medicare, moving into the alternative payment models? And what's going to happen if, as it may happen, many of the people do not move into the alternative payment models and stay in the more traditional payment models?
So just on what's included in the estimates in terms of the current health delivery reform efforts, and certainly there have been some successes, and there've been a number of successes, and to the extent that there have been those successes, be it in the Pioneer ACO or certainly in the reduction in readmissions, I mean those have been effectively built into our forecast to the extent that they have been demonstrated to achieve success. What hasn't been done is an expectation of future developments that have either haven't been implemented yet or haven't been demonstrated to achieve savings yet. And so there's certainly a lot of opportunity for the various initiatives that are being tested now to be successful, and once they've been demonstrated to be successful, then we'll incorporate them into the forecast. As I walk through the effects of MACRA, there are going to be a number of incentives in place that are going to encourage providers to move into APMs, and those providers that are unwilling to today, as the landscape changes, those decisions will very likely be reconsidered, and ultimately our assumption is, as there's a gap between the different payment rates between those that are in APMs versus not, ultimately all physicians will ultimately have to be in those APMs.
Show of hands, I lost track. Walt, and then this lady.
Hi, Walt Francis, independent author and consultant. Comment on several comments and a question. The bundled payment initiative that was announced a couple of weeks ago by the Secretary is a really important innovation. The idea is there'll be a single payment for the cost of a hip or knee replacement. Since most of the current costs, 90% or thereabouts, are in the hospital charges, clearly in the real world, one would expect hospital billing to go down. Let me just say that the proposal as announced is actually fairly timid compared to what could have been proposed. I think bundled payments are a big part of the wave of the future in terms of things we're going to be able to do. This relates to the least costly alternative issue, which has to do with a court decision that took away an important tool from Medicare. But we actually have other ways to get at paying for the least costly alternative, including bundled payments. Paying for generic drugs, we'll pay X $5 towards a generic, you pay $25 towards a name brand drug. That's a form of least costly alternative or reference pricing, various terms for this. So it's not dead in Medicare, it's just constrained in regular Part B payment policies. But bundled payments, just that one proposal is just the tip of the iceberg. Many other possibilities. Another whole area where Medicare has been very timid is in telemedicine. I'm just there are lots of options that aren't yet fully. Okay, here's my question though. Hepatitis C drug has been mentioned several times. This is a new drug, costs about $50,000 for a course of treatment, or 60, I forget the exact number. I believe that there is pretty universal agreement that the cost savings from preventing the sequelae of not having Hep C cured are a multiple of the cost of this drug in terms of the years of lingering, you don't want to know about it. One of the things that often happens if you have Hep C is a $500,000 liver transplant, for example, okay? And this drug is apparently 99% plus effective in curing the disease. Did you include in your estimates, you showed a blip for Part D for the cost of the drug, did you have it wouldn't really probably show up in your charts. Did you include offsetting savings for Medicare Parts A and B? And any reactions the panel has in general to the sort of the interesting case? There's been a lot of criticism of that drug pricing, but relative to what it's going to do for the healthcare system, I think it's, a bargain.
In terms of whether it's a bargain, I'll leave it for others to determine. I mean, from just a financial aspect, and clearly, curing a disease that can have very debilitating effects is an advancement. And the panel members have discussed, what are we willing to pay for versus not. In terms of whether it on net will increase or reduce costs, I can say for certain we are spending the close to $100,000 or even more for a course of treatment, and there's going to be some rebates coming in, so those costs are going to be coming down. But $100,000 today with certainty is different than $500,000, 5 or 10 or 20 years with a contingency. And so on net, to answer your question directly, no, we have not built in specific savings in B or A in the future. We are going to be studying that to kind of quantify what those effects are, and to the extent that those that are getting the treatments earlier on are the ones that are more likely to be the ones that were to develop issues. It is possible that in the short range, in the next 10 years, where we kind of build up, the estimates are done in the short range and the long range, and the short range is more of a bottom-up approach, and that's where we could do some of this work to try to quantify what the effects are of some foregone other expenditures around conditions developing from Hep C. So the specific answer is no, but in terms of the financial question, it's almost certainly going to be a cost increaser.
Yeah, my name is Li Yang. Thanks for your presentation. As government spending and also for Medicare, I think both the concepts should be good to begin with. But the problem is government spending doesn't really increase the general public's health status. Although you can live longer, but I think what I mean is every spending doesn't become the health better for every individual. A lot of abuse, a lot of fraud, and when the data itself have a problem, when the credibility and reliability of health professional has a problem, and anything, even including education, law enforcement, just that everything that asks for more spending, more government spending or project doesn't means it's good for the general public. So I just wonder if you can, based on your data, and see if you can address the issues of people's complaints, and how do you reduce that? How do you really cause the savings from the government spending? Public-private partnership is not necessary.
We've run out of time. I think we know what the question is.
Just to kind of touch on a couple of points. There has been a shift, and certainly a desire for the administration to kind of shift from paying for volume of care versus to paying for quality of care. So that's kind of gets to the overall health. And as to the availability or means by which society as a whole can pay for these, I mean, I'll leave that for the other panels.
Right, and that is the general point, that there is a trade-off inevitably in a resource-constrained world, which is the only world we live in, and we do have to make decisions about how we spend our money. With that, I want to thank the panel for a really great discussion, and thank you as well.